Hi, my name is Michael Denton, and in part with Jean Fredo Lewis and I, Thitshao, we'll be talking about barcode medication administration today. So, what is BCMA? BCMA is an application designed to improve medication administration, documentation within the hospital setting, and increasing patient safety throughout this administration process. BCMA software is designed to improve the accuracy of medication administration processes. It's a software designed to help improve medication administration accuracy, and to generate electronic patient medication records. A little background surrounding BCMA. Nearly 7,000 deaths each year within the US are associated with medication administration errors. This includes prescription, dispensing, and the administration, which we'll be focusing on today. BCMA helps decrease errors and improve the 5 rights of medication administration for patients. This includes the right patient, the right drug, the right dose, right route, and the right time. So what does BCMA require? It requires hospital policy and procedure modifications, workflow adaptations for clinicians and providers, and outcomes for stakeholders. It's going to require an IT infrastructure able to maintain and modify needs within the system. Are we going to build it ourselves, or are we going to buy it as an investment of technology from a third party? And what's the staff education and training required to implement such a system? Changes in the patient-provider culture, and hopefully a positive attitude associated towards this automated practice and technology-based systems. And then we're also going to require compliance with system protocols and safeguards for patient safety after implementation. So, as we implement BCMA, we need to look at why we're doing this. There's a study done by Eric G. Poon, and this demonstrated that the overall incidence of medication doses directly observed to be administered either early or late decreased from 16.7% without BCMA to 12.2% with its use. This showed a reduction of 27.3%. The majority of these errors were medication administration time errors that were late by 1 to 2 hours. After BCMA was implemented, timing-based errors decreased by 23.9%. This is going to help enable clinicians and providers to use standardized systems and safeguards to improve quality patient care. BCMA demonstrated that there are present medication errors in non-BCMA systems, and that the implementation of a BCMA system can improve patient outcomes and reduce hospital risk management. As we integrate technology, barcode medication administration systems are usually implemented in conjunction with an electronic medication administration system, otherwise known as EMAR. This allows for computers to automate documentation of nursing medication actions. This system involves barcode scanning, double ID provider verification, and pharmacy notification and or verification simultaneous to provider medication transcription. Both BCMA and EHR systems allow for authorized users, both providers and clinicians, to access active health information from mobile devices and remote facilities, such as individuals on call shifts, APRNs or PAs who may not be integrated at the active facility, and then providers and clinicians who are participating in rapid assist or codes. So within this, we have to realize that other systems are also going to be included, such as computerized physician order entries, CPOEs. CPOEs alone have been shown to reduce the incidence of serious medication-based errors by over 55%. These will help with inclusion into the EHR system, otherwise known as electronic health record, and like we discussed, being able to utilize these systems from mobile and remote facility access. So what functions are included within BCMA? Well, BCMA is going to help send electronic requests to and from the pharmacy to help coordinate care with the providers and verify order entry. It's going to allow for providers a point of care data entry retrieval system and allow providers and clinicians alike to access a list of variances that identify early or late medication administration errors. It's going to provide the ability to document patient or medication-specific requirements such as pain scores, blood pressures, blood glucoses, and other factors that we may need to store within the vitals package, otherwise known as VISTA. This might be a patient who has a PRN medication prescribed for a certain complication, such as someone who might be observed for hypertension. If their systolic blood pressure raises above 160, we must document the active blood pressure at the time of administration for this medication. So, what are some of the benefits with the BCMA system? Well, BCMA, they're usually implemented in conjunction with electronic medication administration systems, otherwise known as an EMR, allowing for nurses to automatically document the administration of drugs by means of barcode scanning. Because the EMR imports medication orders electronically from either the physician's order entry or the pharmacy system, its implementation may reduce transcription-based errors between providers. An electronic health record is a digital version of a patient's paper chart. EHRs are real-time, patient-centered records that make information available instantly and securely to authorized users for medication administration through BCMA. This is going to allow for real-time automated systems that can be updated instantaneously while providing patient-based care. These systems will not only streamline workflow, but provide efficient safety checks to increase patient safety. Some of the things that surround this as well as some of the notifications that BCMA may alert us to, such as discrepancies between BCMA and available or actively used medication. Hopefully this will help increase medication accuracy, such as those 5 patient rights, the correct patient, the correct drug, the correct reason, the correct dose, route, and time. And then reiterating that this will allow for providers who aren't actively at the facility to allow remote access and telecommunication capabilities, improving communication between clinicians, providers, and pharmacists alike. So as we talk about the pros, we also need to discuss the potential downsides of implementing a BCMA system, such as mislabeling either patients or medications, and what are the barcodes associated with these? And if we don't have a barcode, how do we still utilize the medications in place? If we're unable to read a barcode, do we have systems in place for if we need to override this? And then what happens if we scan the wrong patient or medication, and what alarms are associated with these? We must be careful that if we do scan the wrong patient or medication, we don't develop a complacency for overrides within the system, such as ignoring the BCMA warnings it's providing us because we may have scanned the wrong patient or the wrong medication. And then what occurs if the system's not available, if the intraweb goes down, or if we have a power outage within the facility? How will providers and clinicians alike be able to not only prescribe medications and administer them, but how do we record what we've given? So right now we're going to cover some of the errors in medication administration. There was a study, again, done by Eric G. Poon that showed on units without the barcode EMR, it was observed that 776 non-timing medication administration errors were made, an 11.5% error rate. Whereas on units with BCMA systems, it observed that 495 non-timing medication errors were made, only a 6.8% error rate. This represented a 41.4% reduction in the rate of non-timing based errors. So if you look at the chart above, it's going to show a scale of a study performed by, and I'm going to butcher this name, Schursborough, Wild, and Nelson, done in 2011, that demonstrated the increasing percentage of patients receiving medication-based errors over a 12-week period. This study showed that after implementation of a BCMA system, 90% of patients were receiving medication errors. Most prevalent was timing-based errors at 45%, with 52% of total errors considered to be serious errors, such as providing the wrong medication to the wrong patient. One of the other things we want to recover is medication transcription errors. In a study by Eric G. Poon and others, it indicated that 1,799 orders on a unit without barcode EMARs or BCMA, and observed that 110 transcription errors, of which 53 were potential adverse drug events. In the 1,283 medication orders reviewed on units with barcode medication administration, no transcription errors occurred. So what we're hoping to deal with here is that, one, no transcription errors occurred throughout the studies reviewed, but that we want to maintain interoperability between these health systems, BCMA, EMAR, EHRs, to allow for increased safety measures for patient medication transcription orders. And we believe this is what BCMA will allow providers to do. So just looking at this chart, we wanted to see that what the barcode adoption trend by department was going to be within one of our studies. And this showed that for hospital adoption, between radiology, pharmacy, medication administration, and laboratory, there were fairly significant increases in each facility from both medication administration, pharmacy, and laboratory. Coming to our conclusion regarding our BCMA presentation, we just want to go over some of the important facts we've covered. Well, BCMA significantly reduces medication administration errors. Staff need to know that they should be well trained to utilize these BCMA features and why the features are in place, so we're not trying to override these. BCMA has the potential to create new complications surrounding administration errors. Do we develop alert fatigues and things of this nature that we're bypassing our system? We need to know why the system's in place and what do we need to do to maintain the reasons why we implemented this. BCMA is not a replacement of good clinical judgment. Providers and clinicians alike need to be reminded that we still need to double check visually that we have the correct patients, that we're using the correct medications, and why we're using these. And the BCMA is going to require coordination between clinicians, practitioners, pharmacists, and IT technicians alike to help maintain the longevity of this system, and more importantly, reach out to our patients and improve their quality care. And to end this, BCMA is an ongoing learning process. We need to remember that we're not going to change the system within one day, but that we're going to have to continue this quality of care improvement. So for our contribution today, again, my name's Michael Denton, and in participation, Jean Fredo Lewis and Thitshao. We have all equally participated within this project, and we'd like to say thank you for taking a moment to look into the BCMA-based system. Have a great day.